So I'm going to get you to do some stuff for me today. At any point you're uncomfortable, so I'm coming to start. We're going to start with the Thomas test. So the Thomas test, there's two ways that it's written. One is a modified Thomas test and one is a Thomas test. They both go by Thomas test, so you can do either one. The modified Thomas test is on the table lying down. Sorry, the regular Thomas test, not modified, is laying on a table. You bring your knee to your chest, you're testing this side, and if that comes off the table and you can see underneath it, that's a positive test for a tight psoas muscle. So that's one way, that's the regular Thomas test. The modified Thomas test, I think we do more here. So then bring your knee to your chest, come down, and then that would be, so in that one you're looking to see for the hip flexor, you're looking to see if this is elevated. So his is pretty good here. He's got a short direct fem, because it should be at 90, and he's got a bit of a pull out laterally, which means a tighter IT band, but his psoas muscle is okay. So that was the two different tests that we have. So that's the one test, the Thomas test. The next one would be a Waldorf test. So I just go through the results for that. So that test, we got that test twice, two different ways. Usually you'll just do it the same way. And then the results I talked about the results, if it were negative, I think I talked about all that stuff. I may have missed something. But for Waldron's test, all that is repetitive squats. It's an anterior knee test, so I'm trying to see if there's pain with squatting, pain to stand up. And you're going to face this way so you can see. Stand back over here. Okay, so all you're going to do is squat, wait, I'm going to pull on the kneecap. Go ahead, squat, fall it down. Again, slower, slower, slower. Good. Okay. What I'm looking for is crepitus or pain. And it's a patellofemoral thing. So you're looking for pain underneath the kneecap as a result of patella tracking. So in that situation, it were negative. If it were positive, you would have pain or crepitus, which may indicate patellofemoral. You didn't have it, so it was negative. And then, so that's the Waldron's test. So the next we'll do passive range of motions for the hip. The passive range of motions for the hip, there's 6 of them. And so I want to give my results as Enfield. So I'm going to do this side. And again, you bring your hip, I'm going to do it passively, so relax, bring your hands to your side. Coming up, no, relax your leg, relax your leg. So that's a common thing that happens with hip flexion is people do it straight leg, but you only get this far and you don't get enough range of motion. Because the hip can do that, right? If we do that, we don't get enough hip range of motion. That's not an accurate range of motion of the hip. That's an accurate range of motion of the hamstring. Okay? So for hip flexion, coming up, feels good. Tissue stretch, you feel okay? No problem with that? Okay, that's great. And so then I'm going to come out and do abduction coming out. And that's about 60 degrees. Tissue stretch. I don't need to say degrees now. That doesn't happen. And then for the there's 2 ways to do adduction. It's either all are okay, it's just a matter of difference. So if I can do it like that, and that would be a tissue approximation infield. If I did it like this, it'd be a tissue stretch infield. But either way is fine, you can choose what you want to do. And then, so that's the flexion and the abs, and then we got rotation. Rotation, the easiest probably way to do it, just in terms of, is just watching, keeping rolling the toes out. So that would be a lateral rotation or external rotation, a medial rotation or internal rotation. And so then each one will be a tissue stretch. But if you do it this way, that's fine too. We're coming that way and then that way. Or you can do it while you do extension as well. So that's 5. I've got 1 more to go. I'm going to do extension, turn you over, follow the hip so I don't get lost. I'm going to cross, I'm going to lift the hip up. And then that would be my range of motion as a tissue stretch. And the only thing to keep in mind with this is that sometimes you'll get a different, depending on how you do it, you'll get a different range of motion. So if you keep the knees close together, I can only go like that, and that's about 15 degrees. But if you do like that, you get way more, right? And that's just positioning. So either one is fine, just call it like you see it though. So if you take it out here, that's a normal range of motion, but it's larger than what you'd expect here. Okay? And then the last one, I can do rotations from this point of view if I want. So you don't have to do it once, but you choose how you want to do it. But this is an easy look, just watching it go in. So that's external rotation, and then internal rotation. They're easy, so you decide which one you like. Okay, so that's the 6th range of the motion. And then we'll do a length test for bicep brachial. So a length test for the, you stand up, for the bicep brachial, let's do it this way. We do a normal range of motion of extension, coming back, like that. So that's his normal range of motion. And you don't have to do this beforehand. I just want to show you the difference between this and the bicep length. So that's anatomical position, right hand like that. If we then turn it in, this would be bicep length. All we're doing is putting in pronation position. He's actually getting more this way. Right? I don't think I've seen that before. But that's the kind of difference. So we're looking for a bicep length test. All we have to do is do the same thing, but we do it with pronation. Okay? And so with that one, that would be a good length of bicep, maybe a short length. Here you go, okay, that's fine. So then here, yeah, so there's a little bit reduced range of motion of bicep, I would say. Because he can get extension this way. But all you need is an eyeball. If what you think is normal, it's fine. So what we're looking for is 50 degrees, right? So if he has 50 degrees, that's good, that's normal. If he's here, then it's not, right? So just use your idea of what you're thinking. What you think you're seeing is what you're seeing. And then we've got L3 myotome, so that's the knee extension. So you just sit over the edge here. So for L3, what we're wanting, the main thing for myotome is you're holding it for 5 seconds, and you're looking for a substantial drop off in range of motion or in strength. And it's really hard to describe unless you've seen it before, but the idea of a myotome strength test is a significant weakness because of the nerve thing. So if you have a sustained contraction all the way through that doesn't change, I wouldn't call it a positive result, and maybe it's a weak muscle. So push up, 1, 2, 3, 4, 5, great, that's a good strong muscle. There's no evidence of a myotome. If it were myotome, I would see a substantial break in loss in tension as after a second or two, but you're managing to hold that within the 5 seconds without a problem. And then look at, so that's myotome. And then palpating, I've got 4 structures. What I like about palpation, I think you don't have to, I mean, the thing about landmarks that can be, sorry, the trailing thing that can be tricky is if you have to try and find it by the trail. What I like is the idea of going to it first, knowing where it is for you, and then working your way backwards. So I'll show what that means. Just as a way of getting comfortable with the spot. And come back here, like that. So I know pes anserinatus is here, so I'm going to work my way to this spot to get my spot. Okay. So if we think about 1 bone away or 2 bone landmark, I'll start at the start at the greater trochanter, go down the IT band to the tibial, to the femoral, the knee joint, the joint line, follow that across to the other side, get to the medial joint line, and then go down to that, get pes anserinatus. So then I would make it move by rotating foot to try and get rotation in that spot. Okay? That's president's radius, and that's the kind of the three muscles that attach to it. So that's an example of a bony landmark. The distal attachment of tibialis anterior. So tibialis anterior attachment would be at the first metatarsal or first uniform in that area. So that's where I'm going to. So I'm going to start at the patella, follow the tibial tendon down below to the tibial tuberosity, follow that into the belly of the muscle tibialis anterior, following that all the way through, and then kind of following that all the way through to the spot where I know it is, to be at the first uniform and the first metatarsal. And then I will make that move by rotating the foot, and that was my confirmation. Extension digitorum longus. If we look at, so that's the extensors of the toes go up. So the extensor of the toe, then what we want to do is get these muscles through here. So this is where our muscles are. So I would start up here again at the patella, follow the patella down to the tibial tuberosity, and then follow the belly of the muscle up through the anterior compartment down to the point of attachment on the toes, and then it's digitorum, not hallucis, so I get you to bring your toes up, and I can feel it pop up, relax again, and I can feel the muscle pop up. And then the acromioclavicular joint, you can sit up. Okay, so for this one, I'll start at the sternal notch. Okay, if I start here, press here. Sternal notch, follow the sternoclavicular joint, follow the clavicular all the way across until I get to the acromion, and that becomes my joint. And I can make it move by doing a joint mobilization on the clavicle, or I can move the scapula, I get you retract the scapula, and then it moves as well. So those are different ways to make it move. So the idea then is kind of just trying to get the place that you're comfortable with as terms of where the thing is, finding your way back to that spot, and then confirming it with the way that makes the muscle or the thing move in some way. Right? Any questions? Yeah.
For myotomes, does it matter what range of motion they're in? Like, could I bring them to the full range and then press down for 5, or should I have it?
Yeah, no, it's more about the consistent contraction. I think it's generally thought to be isometric.
Okay.
Good question. All right.